Now I will talk on ankle arthritis. Coming to the causes. Post-traumatic arthritis, the most common etiology, accounting for greater than two-thirds of all ankle arthritis. Primary arthritis, it is very less than 10% of all ankle arthritis. Other causes include rheumatoid arthritis, osteonecrosis of the talus can cause ankle arthritis, neuropathic arthritis, septic arthritis, gout, and hemophilic arthritis. Presentation. Patients will present with the pain with a weight bearing, loss of motion, and in later stage they will have limb difficulty in walking. On physical examination, joint fusion, pain with the range of movement testing, loss of range of movements, and sometimes we will find the deformity. X-ray will show loss of joint space, subchondral sclerosis, and its possible angular deformity. What is the impact of ankle arthritis? Functional limitations associated with the end-stage ankle arthritis. Ankle arthritis can have substantial impact on quality of life, forcing patients to take fewer total steps per day, take a fewer high-intensity steps, and to walk more slowly than patients without ankle arthritis. It affects patients' day-to-day activities. Coming to the treatment, you have to try conservative treatment to all patients. Some surgeons remove the exostosis open or by arthroscopic method. It will help in some cases. Distraction arthroplasty, it is a controversial treatment. Supramellar osteotomy is done in case of limited arthritis with a malaligned ankle, and there should be a normal ankle range of movements. Patient should have normal ROM. Arthrodesis and arthroplasty are the common treatment options for end stage ankle arthritis. Non-operative management, although not as successful as operative management, includes bracing and injections. Some surgeons give intra-articular steroid injections, some surgeons give hyaluronic acid. Sun et al. Studied the effect of 3 weekly intra-articular injection of hyaluronic acid on pain, function, and balance in patients with a unilateral ankle arthritis. They demonstrated that 3 weekly injections of hyaluronic in patients with the moderate to severe unilateral ankle arthritis provided significant improvement in patient outcome and balance and reduced acetaminophen use at 6 months after injection. There is one more study on injections published in JBJS 2012. A separate randomized study using only single hyaluronic acid injection found no difference in pain and patient outcomes compared to patients who received placebo saline injections. You can try local saline injections, hyaluronic injections, or a steroid injection in patients with arthritis. There is no harm before deciding about arthrodesis or an arthroplasty. Coming to the surgery. End stage ankle arthritis that has failed non-operative management is treated with ankle arthrodesis or ankle replacement. Until recently, ankle arthrodesis was the preferred surgical treatment for ankle arthritis, but modern technology and surgical techniques have yielded similar outcomes and patient satisfaction with ankle replacement. Ankle arthrodesis. Ankle arthrodesis has been performed through open, mini-open, and arthroscopically assisted approaches with a favorable union rates of 91% to 99%. The overall union rate was 91% in the cohort of uncomplicated open ankle fusions. Open ankle fusions failed in 9% of uncomplicated ankles with arthritis. Patients who had an open ankle fusion done after previous subtalar fusion as well as those who had a preoperative varus ankle alignment had a significantly higher rate of non-union. This study was published in 2015 Foot and Ankle Journal. That means patients with a restricted motion in the subtalar joint or in deformity had a high rate of complications. There was another study published in CORR 2010. In that, union occurred in 93 of 94 patients. That means 99% success. Ankle arthrodesis with the screws provides a high union rate, reliable pain relief, and favorable functional medium-term results according to this study. Fusion was achieved in 91% after primary surgery. Ankle arthrodesis using a 2 incision 3 screw technique was a reliable and safe technique for the treatment of end stage osteoarthritis of the ankle. This was published in Foot and Ankle Journal 2011. The non-union after primary open ankle arthrodesis was significantly more likely to occur in patients with a previous ipsilateral subtalar fusion and a preoperative varus alignment. Comparison of ankle fusion rates with and without anterior plate augmentation. The non-union rate in the compression screw was 15.4% and 7.7% in the anterior plate augmentation. The revision rate was 7.7% in the compression screw and 2.6% in the AP group, anterior plate augmentation group. This study was published in Foot and Ankle 2017. That means plate and screw is better than compression screw for the ankle arthrodesis. Concerns following ankle arthrodesis. Ankle arthrodesis is not without any side effects. Even if it is successful also, it leads to adjacent joint arthritis, subtalar and talonavicular disease. In one study of 66 ankle fusions, authors reported significant radiological progression of arthritis in all adjacent joints. However, Thomas et al. Found that only 4 of 26 patients developed subtalar arthritis during mean follow-up of 44 months. Obviously, the length of follow-up is important in identifying adjacent joint arthritis. 44 months is a very short period. Patients will definitely develop arthritis in subtalar and talonavicular joint in the long run. There is one more study on ankle arthrodesis published in JBJS 2001. They reported adjacent joint arthritis in all 23 patients they studied after mean follow-up of 22 years. They found that 91% and 57% ipsilateral, subtalar and talonavicular joints respectively developed moderate to severe arthritis. That means almost everybody will have an subtalar and talonavicular arthritis in the long run. Ankle replacement is one more option for ankle arthritis. There are some studies on that one. Randomized comparisons of ankle replacement to ankle arthrodesis are lacking. At least one database study demonstrated significantly lower readmission and wound infection rates for ankle replacement. One prospective and non-randomized study reported equivalent patient-reported outcomes between ankle arthrodesis and ankle replacement and higher complication and reoperation rates with ankle replacement. In an even longer term follow-up study on the same mobile bearing prosthesis, Burner and colleagues reported 71% of implant survival rate at 10 years, but only 46% survival at 14 years. Conclusion: post-traumatic arthritis is the most common cause. Try conservative treatment first in all cases. Ankle arthrodesis is a good option for severe cases. Ankle arthrodesis can be fixed with a screws, plate, bone block or external fixation. Correct the deformity if possible for successful ankle arthrodesis. Ankle replacement should be tried in selected cases.